Our first topic for discussion looks at vaccine hesitancy. A few weeks ago, we launched a question in our app to understand levels of and reasons for vaccine hesitancy. Over 1 million people responded to our question, would you accept a COVID-19 vaccine if you were offered one? And while almost 95% of people did say yes, just over 5% of respondents were either unsure or unwilling to accept a vaccine. And taking a closer look at the hesitant 5%, what you see on your screen now is a bar chart of the reasons people cited for being hesitant. The top 3 reasons were worries about long-term side effects, not knowing enough about the vaccine, and concerns about adverse reactions. Anna, as the principal investigator on various vaccine trials, what are your thoughts on addressing these concerns, given the pace at which we'll soon be asking all adults within the UK to accept a vaccine?
Well, firstly, I think it's amazing that 95% of the people are responding were keen to accept a vaccine. And I think these reasons that are shown just highlight the sorts of things people are nervous about whenever they have a vaccine, that they don't know what side effects they're going to have. It's very common to wait till a friend or a family member's had a vaccine before going forward to have it yourself. I think that's absolutely normal. We tend to be very scared of things that are new to us and things that we haven't been exposed to before. In this context, we have to remember that we've always got to think about the risk of not having the vaccine. And that's a really, really real risk. And I think people forget just how many people have become very ill with COVID-19 or are dying from COVID-19. So that when we hesitate and we wonder whether we should really go ahead, we have to remember that if we don't go ahead, we might catch COVID next week.
Absolutely. Tim, did you want to add anything to that?
Not really. I think the UK public is actually much more pro-vaccine than many other countries, and that's just a factor. When you do similar surveys in France and Italy, you find much more resistance to it, Austria and Germany, etc. So I think we've got a public that is much more in tune with science and getting rid of this virus by these means. So I think it's all very, very encouraging. And it seems to be the closer people get to having a vaccine, the more likely they are to accept it as well, rather than the opposite. And hopefully the data we're going to be talking about today will reassure people, those 5% as well.
And I'd like to just mention, because some people have put pregnancy breastfeeding, and I think that's come up as a worry for a lot of people, because if people will remember, when the vaccine was first rolled out, the very first couple of weeks, it was advised that people who were pregnant or breastfeeding didn't have the vaccine. Fortunately, since then, the advice has changed, and now people are advised to consider their risk of COVID compared to their risk of vaccination. And therefore, now some pregnant women and people who are breastfeeding are going ahead to have the vaccine.
Absolutely. And Anna, you mentioned earlier about the risks of potentially not taking up the vaccine. I just wanted to dig into that point a little bit further. How does the emergence of new variants, for example, the so-called Kent strain, impact the effect of vaccine hesitancy? Does it mean that we might need to ensure that a bigger proportion of the population is vaccinated to protect against these variants that might be more transmissible?
I don't actually think it's the new strain that means that it's important to be vaccinated. I think it's important to be vaccinated because more than 100,000 people have died in the UK. I think that just shows how important. The new strain, fortunately, the same measures, mask, hands, face, space, are going to work in the same way. It's just that you have to be even more careful. So it's even more important that as part of that, you have your vaccine.
Makes sense. And something else that we found in our data was that in terms of people who are more likely to be hesitant, it turns out that those who are in minority ethnicities, such as those who identify as Black, Asian, Middle Eastern, for example, expressed a higher rate of hesitancy. We also found hesitancy highest in areas with more social deprivation, including, for example, London and Northern Ireland. So Tim, what might this mean for the future of the pandemic if we continue to see higher rates of hesitancy within minority ethnic groups and socially deprived areas?
Well, I think it is an important problem we need to address, because these are the actual very groups that have often 2 or 3 times the risk of the rest of the population that are keen to have the vaccine. So I think it just means we do have to reach out to those groups, particularly, and that's one of the things we're trying to do with King's Health Partners, is actually get to our local populations, and rather than going through mainstream media, possibly by use of the app, because everyone's got a mobile phone, it's finding different ways to reach these groups and reassure them, because I think the standard approaches aren't working as well as they could be. So I think that's something that every council and every trust and GP surgery needs to address, perhaps looking at different ways to get to these groups who are more resistant to the idea, because actually the benefits for them are even greater, and we need to get that message across. But I think it is important that everybody gets equal access to this and isn't put off by some just cultural trends.
Yeah, agreed. Okay, just having a look at some of the questions from Slido. There's quite a few questions from members of the audience about mix and matching vaccine types. And I think there's some hesitancy about potentially having a different vaccine after having, say, the Pfizer vaccine first, and then having to have the AstraZeneca vaccine. What's your advice to those who are hesitant to accept a different vaccine dose if it's offered to them?
So my understanding is that this isn't something that's being offered routinely. So most people, when they're being invited for their second dose, are being invited for the same vaccine again, because that's what the trials have been on so far. Obviously, with time, all this science is going to change. So as weeks go by, the information will be different. But at the moment, that's the guidance. And this is really if you attended an appointment and there wasn't, for some reason, there wasn't a supply of the one you were supposed to have. It's saying, okay, don't send somebody away who's already there for a vaccine. Surely it's better to get a vaccine than be sent away unvaccinated. So that's really what that's about. Scientifically, it makes sense that if you've had as many doses of vaccine as you come to have, it will be an increasing amount of boosting or immunity. So this is how there are various vaccines where we give different vaccines intentionally. For example, in the Russian vaccine, they give 2 different vaccines intentionally. Gets a bit complicated because you have to then work out who's going to have which vaccine first. So it's much simpler to give the same vaccine twice, but there's no reason to worry that it wouldn't be safe to do something different.
Yeah, and I'd just like to add to that in the future, we're likely to have a whole range of different boosters. And as we can probably discuss in a minute, if you've already had COVID, you've had one sort of immune reaction and you're going to get another one. So I don't think it's inherently wrong about getting a slightly different immune boost. And it's quite possible that actually it might be beneficial to have, one vaccine that's mainly pushing the antibodies and the other one that's more helping the T cells. At the moment, there's no reason to really worry about it, and there's potential that it might actually be a good thing. So I think people should be pretty relaxed about it. But as Anna says, I don't think that's the plan for the next few months anyway. So I don't think it's on the horizon.
Absolutely. Okay. And what if someone's invited to take their vaccine now and they're still kind of not really sure whether to go for it or not? If they were to end up turning it down at the point of being invited, is there a chance that they would be able to get it again, or have they missed their window of opportunity?
No, so if you're eligible for the vaccine, you're eligible for the vaccine, full stop. So if you're 82 years old and you miss your appointment because you can't get there, as has happened to many of my patients, then absolutely, you simply need to make contact with whoever offered it you and say, sorry, I missed it. Please, can I have a new appointment? So once people are eligible, they remain eligible.
Okay, that's reassuring to know. Okay, why don't we move on to our second topic? I think there's a lot of questions from audience members around this, so let's spend some extra time on that, which is what we know about how well vaccines are working so far. So let's take a look first at what data from the ZOE COVID Symptom Study shows. So for this analysis, our data scientists focused on COVID vaccines in healthcare workers. And that's because an impressive 74% of contributors to the study who are healthcare workers, have already logged a COVID vaccine with us. Based on around 13,000 PCR swab test results per week, this chart maps out the change in COVID positivity rate over the past month. The blue line represents positivity rate in healthcare workers who are not vaccinated, while the purple line represents positivity rate in healthcare workers who received their first COVID vaccine dose at least 12 days previously. And the gap between the two lines shows a significant reduction of 50% in COVID positivity rate amongst those healthcare workers who did get their first vaccine dose. And this reduction of 50% remains consistent as the overall population's COVID case numbers decline. Tim, what was your reaction when the data science team first presented you with these results?
I was delighted. It was fantastic news, really, that we were seeing this without having to wait, for 3 months to get a result. And you can see these graphs going down, and that's because the rate of the virus has been going down in terms of new infections for the last 4 weeks, according to our data. And so this reflects the fact that the risk, even for the unvaccinated, is slightly lower than it was at its peak at the beginning of January. And we're seeing a very consistent effect in this group. So to get, I think it was 53%, on average in that sort of 2 to 4 week window after a single dose is excellent news, really. And I think this is the first sign that in real life, outside trials, what the effect is of a single dose. And it's really proving that the data that 280,000 fantastic app users have given us is really accurate and working exactly in line with what we would expect. And so the only caveat here is obviously that it's only after 12 days. And I think this brings on this other point that, at no point after you've had a vaccine are you 100% protected. But particularly that first 2 week period, there's like zero protection. And many people might be much more relaxed, and there's some evidence that they aren't as concerned about prevention of vaccine and might rush up to relatives and go on public transport more, and that's going to do that. So that's a real important public health message for everybody, that actually the risks are really high just after you've had the vaccination, but then it starts to improve. And we're very interested to see if we can get that 50% even further down by following these people and by all our loggers telling us what's going on between that period up to 12 weeks, because this would seem to be vindicating the approach of the government at the moment about the 12-week delay, if we can get at least 50% protection very rapidly.
Yeah. And on that topic, I think many of us heard in the news today that the Oxford AstraZeneca vaccine has been shown to have 76% efficacy, even just after the first dose, for 12 weeks, in fact. Anna, do you think you could help us kind of unpack just the information around that, help the audience members understand that better?
Sure. So really exciting paper, and really pleased to have been involved with the team producing that work. And it shows us what we thought already, which is that one dose really has a strong impact. It's the same as Tim's data, as this data that you're showing us from the app that all of you out there have been giving us. It shows us that one dose really, it will keep you out of hospital, for example. That's not what the trials were looking to measure, but we're seeing from all the trials and all the vaccines that people who've had the vaccination are coming to hospital less. And we're seeing that in the real world. So in Israel, they're seeing a real drop in admissions now that they've vaccinated so many of their population. So this is absolutely fantastic news. What's also really exciting about that paper is it's the first paper to show some promise that we might be able to also reduce the risk of people passing on the virus. So not just having infection, but passing on infection. But I think you have to look also at this graph that you're showing and see that there are still some people with the virus. So when you've had your vaccine, just as Tim said, you can't presume yourself to be 100%. You can't go and visit an elderly relative presuming that you'll be absolutely fine. That's not how the vaccines work.
Yeah, I think that's a very important message to reiterate. So just to be very clear, at what point after somebody's had their first or their second vaccine dose, can they, say, throw away their masks and go out and see their relatives?
Well, it's all dependent on what else is happening around you, because, as we said, there's no 100% protection from the virus. You're just, even if you get 90% protection, there's still a slight risk you'll get it, even if it might be milder. So the context is very important, depending on your own health, but also particularly, it's not just about individuals, it's about getting the level of virus down in the population so that your risk is really low. But if you did it at the moment, well, there's still 400,000 people who have the virus around you, you'd be crazy, because you're still running a high risk. But if in a few months we can get this risk really low, then hopefully people who have been vaccinated can relax. But I would say at the moment they shouldn't really change their behavior because of it, while there's so much virus around. I don't know if Anna would agree on that.
Yeah, I'd absolutely agree. I think it's all about context and remembering that in the summer, hopefully you can have some fun. But while rates are so high, it's so important to be careful.
Okay, so I guess the summary of that is even if you've had the vaccine, keep your behavior the same for now until we hear otherwise. Okay, and so all of this is like very, very positive news. Should we be worried at all about kind of the effectiveness of vaccines against new strains?
I think we knew that there would always be new strains. I think we've been quite lucky, because here we are in the autumn, a year after, well, we're in the winter now, a year after the virus was found, and we have a vaccine that remains effective. And that's wonderful, because if you look at flu, we tend to need new vaccines every single year. I think we're starting to realise, and we always suspected scientifically, that these vaccines, we would need new ones for new strains. And I think that's becoming clearer in the news, with the news that, for example, the Novavax vaccine is still effective against the South African strain, but less so. So it's about the fact that it's still worth having a vaccine. Please don't not have a vaccine because you think it isn't going to help you. It's just that then that vaccine may need some boosting later on, as Tim referred to earlier. Yeah,
and I think the context is important, because the media have actually sort of said, well, this South African strain could mean that, vaccines are not helpful, and we nearly, start to panic. But we're just talking about a few percentage differences in these trials, so showing that most people are still protected, but there's a slight difference depending on which strain you had. It's absolutely not a all or nothing type effect. So that doesn't really change things from a population perspective, because it will still really drive down the virus and make it much more difficult for it to, transmit and cause major outbreaks, etc. So I think that we have to bear in mind, and so it's quite reasonable, as Anna said, that we are going to get new variants, this year, next year, and we're going to be little boosters just to keep tweaking this so we try and get maximum protection, but we're never going to get 100% protection anyway. We have to get used to that. That's going to be a fact of life.
Yeah, and related to this question of, the virus mutating, new variants, etc., I noticed an interesting question from Juliet Ricks. Tim, are you concerned about partial immunity due to single vaccine doses creating an environment for more mutations that dodge the vaccines?
I'm not particularly, no, and I think these are theoretical concerns, and it's much better to get the virus reduced by vaccinating people and get levels very low than to be worried about theoretical concerns about potentially generating more new variants that would happen anyway, and happen in nature anyway, because there are some people whose natural immunity allows that virus to persist for a long time in them, and it can evolve in nature as well. So I think that's the wrong emphasis. I'm not saying it can't happen. I just think it's not the thing we should be worrying about. If we've got vaccines that work between 70 and 90% or 95% in getting rid of this virus, then absolutely we should use them, whether it's one shot or two shots. If we can drive the levels down, we're really not so worried about variants, which will happen anyway. That's my personal view.
And Anna, what about you?
I fully agree with Tim on this topic. I feel in the news like it's taking away from what's important, and what's important is people need a dose of vaccine, and these variants will happen. Of course they'll happen. So the sooner people just get that dose, the better, really.
Yeah, I think it's much too much talk about these variants and less about the clear knowledge that we can really drive down these rates as they've done in Israel by getting things done quickly and not overthinking all the potential problems.
One of the other kind of potential problems that I think some people are concerned about is, whether these vaccines are effective, equally effective for everyone. So we have a question here from Simon Beasley. Tim, what's the evidence behind the recently reported information that the AstraZeneca vaccine has less than the reported protection in the over 65 age group?
Really, that comes from the fact they hardly studied any people in that group in the original studies, so there just wasn't the data, and that's led several European countries to say we're not going to select that particular vaccine. We're going to go for one that has got more data in the over 65s. But having said that there's other data, and Anna will know this better than I, about antibodies being perfectly well generated in the over 65s using that vaccine. So the fact that virtually all the vaccine studies around the world are showing effects across all age groups, and there is a correlation between the antibodies you produce and the efficacy of the vaccine, I don't think people should be worried. And I think personally, this country's right to give it to everybody. That's my personal view, but Anna might have some more info on that.
Yeah, just from my experience in the trials, of course, the over 65s, people were shielding. So we didn't feel at the time that it was appropriate for those people to be the top of the list of the people to come and be volunteers. It involved traveling to vaccine centres. So that's the history behind the data. And that's why there's just small numbers. Some people did come and do the trial, and that's great. But if it works in the younger people and the antibodies are good in the older people, there's no reason to think it's not going to work. It's simply that the regulators, some of the regulators, for example, in Germany, felt that the numbers of cases were too low, which is a good thing. People stayed home and didn't catch COVID.
And what do we know about how long these antibodies stick around for after a vaccine dose? And what is the kind of the decay rate afterwards? Interestingly, there's a question from Margaret O'Hara here who says, had the AstraZeneca vaccine 16 days ago, did an imperial antibody test yesterday as a volunteer on the study, and the test was negative. Has the vaccine not worked?
Yeah, so I saw that question in advance, and it's actually a question that comes up a huge amount on emails to me and chats, because what happens is the antibody tests are all different, and some of the antibody tests test for something called the antibodies to the spike protein, and others for the nucleocapsid, and all the vaccines that we have currently in the UK are based on the spike protein. So if you have an antibody test against the N protein, the nucleocapsid, it will be negative if you've been vaccinated. It will be positive if you've had infection. That's really helpful, because it means if somebody comes to clinic and I want to know if they've had infection rather than vaccination, there is a way of teasing that out. But it means that you shouldn't worry if you have an antibody test that comes back negative.
Okay, so perhaps Margaret had an antibody test that was testing for natural infection then, as opposed to the vaccine.
Exactly.
And also the timing as well. It may not go up in the first few days, and can take a couple of weeks before you get the antibodies, provided you got the right test to look at it. So you would expect antibodies, after a couple of weeks, which would fit in with the data we've got showing that's when the protection starts to kick in.
And do we think that we should expect to see kind of yearly COVID vaccinations each winter as a result of, antibodies declining over time, potentially, after 6 months, and, new variants and things? I think that was a question from Slido as well.
So I think we can expect to need to have future vaccines. As to whether it will be every winter, we have to wait for the science to tell us that, because like I said, we've managed to go a whole year this year. But I think, yes, we can expect in the future that we will need further vaccines, something akin to the flu vaccines that we have every year.
And there's been a lot of questions about the, the 12-week window that the government has opted to push for. Question from Lynn: what will happen if the government fails to provide second doses within the 12-week window? Would we have to repeat first doses?
No. There's no real difference, really. It's not a, so there's no real, it's not a window you have to start again. It's just a question of when you're getting your booster. So if you've had that first dose, it's just when you get your booster again. And if it isn't 12 weeks, it would be 13 weeks, 40 weeks. So there's no, people shouldn't get too obsessed about the exact day and date of that 12 weeks. For all we know, 13 weeks might be better than 12 weeks. We don't know yet. So people shouldn't worry. I think it's highly unlikely that we're going to run out of all supplies for this.
Do we know if they're running any studies to test longer time periods between boosters?
I
don't know. Anna, do you know, are they?
Well, there's in the AstraZeneca published data from yesterday, you'll see that we're looking at the people who had the boosters later, because inevitably in trials people do have doses a bit later. So when they compared people who had it at less than 6 weeks to people who had it more than 12 weeks seemed to be an improved efficacy. So I think over time we will see this, and we'll see it in real world populations, and we'll see if waiting longer. And of course there'll be a different kind of booster potentially if there's then a different kind of vaccine in due course.
And Anna, do you think, that's data from AstraZeneca, do you think the same is going to be true for the Pfizer?
Yeah, I believe it's likely, but there isn't currently clear scientific evidence on the Pfizer longer dose. I'm sure people will study it, but it isn't, as far as I'm aware of, I haven't seen published data today.
Theoretically, there's no reason that it shouldn't work in a similar fashion.
Yeah, exactly. So this is all about priming and boosting. So priming being when you start your body recognizing something, and boosting is the second dose. So that's why both Tim and I have referred to a boost and when we boost. The priming can also, it seems, most likely be your infection. So some people who've had an infection can then have their vaccine will then improve that response as well. So there's various ways you can prime and boost, and there's no reason to, and it's generally a good thing if those things happen spaced out.
All right, just looking at the Slido questions again. Tim, I know that you want to move away from talking about new strains, but a lot of people are interested in finding out, is the Pfizer vaccine as effective as the others against these new strains?
Well, we don't know for sure, but given that the initial results of the Pfizer vaccine were spectacular, over 90% efficiency, even if it did drop 10%, it wouldn't really have a material difference. I don't think anyone is expecting that any of the new strains don't work at all. So I think it comes back to my earlier reply that these are all relative, and so if you can get a vaccine and it works 10% less well on some new strain than another one, it really won't matter if everyone's had that vaccine, because that strain will disappear. And I think that's the key thing here. It's that population approach that we need as we move from getting 10 million people vaccinated to 20 million people. I think that's the really important message, rather than focusing on this individual person and individual variant, because we know that the same measures that we saw in reducing the old variants are working on the new variants. So just because they have a 20 to 30% higher transmissibility doesn't mean they're not they don't respond to population non-drug measures. So I think that really people have just got to slightly change the mindset. And I know people are worried about these new variants, but I think if we realize that we work as a population together, then it becomes much less relevant.
And also, is it right to expect that Pfizer's probably working hard in the background to create some new boosters that could potentially face off against these new strains?
Absolutely. I mean, Anna can give us some more details on this, but I mean, all the companies are working on just tweaking their original one just to take account of these new variants, and these things can be rolled out very quickly. So in just a few months, and so that acts as a sort of insurance policy that we can keep pace with these changes. But Anna might know more specifically about the Pfizer work.
So the Pfizer and Moderna, they're all, and the Oxford vaccines, they're all really quick to change. That's why they came on. When people worry that they would develop so quickly, it's because actually it's very quick to change inside as well.
What do you mean by that exactly, Anna?
So what that means is it's not going to take a whole nother year to change to a new vaccine. So it's taken a long time to get to this point because they were the first vaccines. But then now when we go to new versions, we don't have to test on quite as many people. We can change it quickly. There's no reason to think it will behave differently. So that's great news, because it means you can get on and then start to vaccinate people with different strains if you need them as you have the new vaccines.
Okay, thanks. We've been talking a lot about efficacy, but there's a question here about what does efficacy actually mean? So question from the fantastically named Bippy. If 60% efficacy means for every 40 people who catch COVID in the vaccine group, would there be 60 in the control group?
For 100 in the control group, there would be 40 in the vaccine group. But that would be based on you have to look at the outcome of the trial, and they are a bit different from different trials. So that's why it's a little bit hard to compare a Pfizer or a Moderna result with an AstraZeneca result, because they did all slightly measure things differently, but they pretty much all looked at mild COVID, which was a positive PCR, a positive swab for COVID, combined with some mild symptoms. The reason they didn't look at hospitalization for COVID is, fortunately, that's much less common. So what's great is that the secondary outcome, which is another thing they look at, but they don't put that in the headline, was really great at preventing hospitalization. So whilst, for example, the AstraZeneca, they might put 70% or 76% on a headline, if you then look at the number of people who were in hospital more than a couple of weeks after they had their vaccine, it was then 22 in the group who had the control vaccine and just a none in the group who had the actual vaccine. So you can really see that those numbers don't tell you everything about how a vaccine works. And similarly, those numbers, when we come to these new strains, if we can keep people out of hospital because they've had a vaccine, that's really important, even if that headline number is perhaps 10% lower.
I think that's the other point, is from the trials, we don't really know about the severity, whether, when we say something has 60% effectiveness in reducing it, how much that also reduces the symptoms, etc., and the duration. So that's something that because those events are rare and they needed more people. So that's why what we're seeing in the app of 50% reduction, we need to look more carefully and see if those people had it for less time, and whether those people had less visits to hospital, etc. So I think that's the added advantage that might be there that isn't seen in those pure percentages, which is just really on PCR test.
Thanks for those explanations. Okay, just two quick final questions within this topic. First one from David. So if 1 in 7 people in England have had COVID and 10 million have had the injection, the vaccine, I guess, does this suggest that almost 20 million people have immunity?
It's a good question. And I think it would have meant that if everyone had had COVID recently, but a lot of people who had COVID had it in the first wave in March to May. And, we do know those people can get reinfected, although the rate is very, very much lower. But I think we can assume those people have some level of immunity, and that does, I think, paint a more optimistic picture than we have at the moment. And it's something that doesn't get much attention. And I think it's because, the government wants everyone not to think about, did I have it, did I not? They just want everyone to get vaccinated. And we can come on, we've got some data on that in the next session, I think.
Okay, and the final question from Lizzie. So my husband had positive antibody tests and I had a negative one, yet we were both ill at the same time. Is it true that T-cell immunity occurs without antibody production?
That's a very tricky question. We know that you can definitely have COVID without developing antibodies, and there is a difference between people. It's also linked to the severity of the illness. So people who had very severe illness in hospitals, nearly all had antibody reactions. So we do see a variety of immune responses to the virus, and we looked at twins, for example, and saw even identical twins had a different response to the virus in terms of their immunity. We don't know yet how that affects your risk of reinfection or whatever.
Okay, thanks, Tim. On to our final topic, which is exploring the after effects of vaccination. So our data science team is still working on this, but we're starting to see a few interesting things already. So these initial analyses were from around 40,000 recipients of the Pfizer vaccine. And again, they were mostly healthcare workers. What we found was that most people experience some level of pain or swelling on the arm near the site of the injection for a few days afterwards, what we call local adverse effects. And a small proportion of people experience systemic adverse effects. So these can be things like headache, fatigue, and other symptoms not localized to the injection site on the arm. They're usually mild and appear most frequently 24 to 48 hours after vaccination before starting to disappear in the following days. Interestingly, we observe a higher rate of systemic adverse effects in people after their second vaccine dose compared to their first. Anna, what could be behind this?
So this is quite a recognised thing and was written about in the Oxford trial, although interestingly, in the Pfizer paper that I just had a look at, as I read it, they didn't see this as much in their trial. But we do expect this. So as I talked about before with the idea of priming and boosting, when your immune system has seen the virus before, you tend to have a bit more of a response when you then see the antigen again. And that's also, it's been seen to be true perhaps of people who, for example, had COVID and then have a vaccine. They might have a little bit more of a reaction. We call that reactogenicity. It's not completely equal to your immunogenicity. So it doesn't tell you, because you have more fever, that doesn't mean you're more immune. You can't presume it to, although it does suggest that your immune system is, of course, doing something. And perhaps if you were on a lot of medicines that stopped your immune system from working, you might feel reassured if you then had some sort of side effect, because you would feel that you can feel your immune system doing something, so to speak.
Okay, so in some ways it's almost a good thing to have a couple of side effects, because it shows that it's definitely working, but we shouldn't mistake the size of the side effect or something to mean that it's a bigger immune response.
Yeah, and it's not a guarantee, but I think it does. People do feel reassured. Colleagues of mine will say, oh, I had a bit of a fever. It must have been doing something. Yeah, so it is to be expected. And it's nice to see that these side effects were the same sort of side effects as we saw in the trials, which is great. So it just reassures you that in the real world, we're not going to expect something very different. You know, it was tested on tens of thousands in the trials, and now here we are testing it on millions, and we're seeing the same sorts of things, which is really reassuring.
And I think the other thing to point out is that these levels are pretty low. So, 80% of people had no problems. And this level is actually similar to the placebo arm of the Pfizer study. So people just get nervous and anxious, and sometimes they get it's called a negative placebo, nocebo effect of what's happening. So, which was about 17% in the group that just had a bit of salt water injected in their arm.
So, Tim, do you think it's possible that people who might be a bit more anxious, nervous before the vaccination, that they might be more likely to experience side effects afterwards?
I think that's highly likely, yes, and more. But I think generally most people should be reassured by this data, and so hopefully anyone listening who hasn't had a vaccination should be less worried when they go into it, to say there's nothing dreadful is likely to happen.
Oh, and do remember, you can take paracetamol. So when people do, having some pain in your arm after a vaccine is completely normal. And what's lovely and reassuring on these graphs is you can see these side effects go away. So I think if you go back to your first graph, people worried about long term, but actually it's very short term. It's if you're going to have a side effect, which not everyone does, it's a little bit the next day. You can probably predict that and take some paracetamol the next morning and feel much better and get on with your day, for example.
Yeah, you mentioned it's fine to take paracetamol. Is there anything that people shouldn't take, perhaps, afterwards?
If you're having heavy immunosuppression, then sometimes it's not that you would avoid it, but sometimes the dose is timed so that you get the best response to the vaccine you can. But many of those people, of course, would need the vaccine and would have the vaccine. So it's not, but no, there isn't something that you can't take the day after, for example, no.
Okay, that's good to know.
Perhaps don't take a bottle of vodka, maybe. That
I don't think the doctor would prescribe that anyway, would they? Okay, so something else that we noticed in our data was that those who previously tested positive for COVID report systemic adverse effects after vaccination almost twice as much as those who never got infected before. Tim, what could be a possible explanation for this?
Well, I think this is really fascinating because it's really sort of suggesting that if you had you've had COVID before, your first vaccine is really behaving a bit like the second one, like a booster, where you are seeing higher rates of side effects, suggesting that people already had an immune response and they're getting an even bigger booster so that their immunity is going to be stronger. So I'm expecting once we analyze and get a bit more of the data, we're going to show that this group who previously had COVID maybe 6 months before have an even bigger protection rather than that even bigger than the 53% after that single dose. And I think it really invites the question about whether, with a bit more data, we might be able to say that these people don't need a second booster, that really they've already had their first one, which is the COVID, and the second one, which is the first vaccination. So, and that would potentially save, around 10 million vaccines, or at least it could be delayed maybe several months more. I'd be interested what Anna thinks on this, but I think this is a really exciting area of research that our app can uniquely give this data for, because we know so much about the people who've been logging since March about exactly what's happened to them, and also whether it's different for people who had COVID in the last 4 months to people who had it in the spring. Some of those might not get that same benefit. What do you think, Anna?
So I think this is side effects that we're seeing on this, and what's really nice is that yesterday or the day before, there was a paper published from New York that also showed that antibodies were clearly seemed to be higher. I can't say clearly because it's a small data set, but I'm sure we'll get more evidence of this, that if you've had your COVID before and then you have that first dose, you can put up your antibodies to the level similar to people who've had their second dose and never had COVID. And absolutely agree, Tim, that that could really help us save some vaccine. Although the problem, of course, and the challenge is that not everybody knows if they've had COVID before. So, and it isn't dangerous to have another vaccine. So absolutely, you can still go for your next vaccine if you had a reaction and you've already had COVID. But we'll wait for more evidence and we'll see over time. And perhaps by the time you're due to go for that appointment, we'll know even more about this.
So at the moment, you're only asked to say if you've had COVID in the last few weeks, and that stops you having the vaccine. But seeing this sort of data and the data you talked about antibodies, do you think we should be considering increasing that time to say, at least 3 months or something? Or
well, it's likely that for 3 months you don't need a vaccine. So if you've just had COVID, it's likely that you're protected for your first 3 months. So that perhaps if you're prioritizing, it gets very complicated. So in terms of running a vaccination program, it makes sense to just invite everybody. We don't have the, if we were going to do blood tests on every single person to see if they had antibodies before they had a vaccine, that would mean doing blood tests on millions of people, whereas actually that time could be well spent simply giving them a vaccine. We don't think it's dangerous to have an extra dose. So I think it's something about the logistics. But yes, over time, it might be that people say, well, if you've had the infection in the last 3 months, you don't need to attend so urgently.
Yeah. Okay, that might be reassuring for people just to remember that virtually all the studies of past COVID have showed that nearly everyone has antibodies at 3 months, and most have it at 6 months, but it does start to fade. So that 3 months is, really, really rare to find anybody in the world who's got reinfected.
So looking at that group a bit further, so of people who've previously had COVID, and specifically at those who've previously had long COVID or maybe still are suffering from long COVID, there's actually a question here from Slido. Is it safe for a long COVID sufferer to have the vaccination, or could it produce an overload on the immune system that might already be struggling?
So long COVID is thought to be an inflammatory response to the virus, but that's not to the vaccine. So there's no suggestion, and people have looked at this, there's no suggestion that because you had long COVID, you should have a different response in terms of a worse outcome from your vaccine.
Okay.
I think that the data so far is reassuring. We don't have that many real life examples yet, but hopefully, again, through the app, we've got around 20,000 or so long COVID stuffers still logging that a number of them will get the vaccine and we'll be able to get some data. I think that'd be really important and reassure those people that nothing untoward is happening. But I think there's no reason to think it will cause any problems, certainly.
Okay, that's good.
Please don't presume you're protected if you have long COVID. So I think there are certainly some cases where people don't have detectable antibodies but have been given a diagnosis of long COVID, or perhaps they had their COVID originally quite a while ago. So I think it's important to not presume yourself to be protected, but to presume that you also might need the vaccine.
Yeah, and in a way, this 3 month rule it's sort of from the time of first getting the infection rather than time of last symptoms. That's the way to look at it.
And looking at the effects of the vaccine on another specific group of people, we have a question here from Rebecca Baker asking, what evidence is there on safety for those with autoimmune diseases? Were any included in trials? Can we be sure of no bad adverse effect or disease flare-up in these people? Anna, if you'd like to take this one.
So in general, people with autoimmune disease aren't included in trials, and that's true across vaccine trials. So it wasn't specific for these particular vaccines. And the reason being, it's also people who are on immunosuppressants who aren't included in trials. And some of this is about measuring, trying to get a measurement of the responses in the general population for the results of the trials. That doesn't mean that they're dangerous in those groups of people. What we do know is that COVID is dangerous. So whenever you make this calculation, you have to weigh it with your risk of catching COVID tomorrow, or perhaps you're on an immunosuppressant medication for your autoimmune condition, then you may feel, you're at quite high risk. If you're not being offered a vaccine, then of course you have time to have a think about it. If you're being offered a vaccine tomorrow, then you have to weigh up what your risk is and be reassured that we think it's very unlikely there's going to be problems, but like I say, if you prefer to wait because you're not at risk and you're not being offered, then that's different.
And just the other sort of general reassurance, it's not directly correlated, but most of the data shows that people with autoimmune diseases actually got less COVID than people without them. So in a way, having an autoimmune disease might have actually given some protection, which is counter to what we might have thought, and many people do believe. So I know there are lots of data on people with rheumatoid arthritis seem to have much lower rates than believed. So I think this can go either way, really. We don't know the answer, but I don't think there's any reason to think it's all necessarily bad. I think that's the reassuring bit of it. And of course, it's not. There are some vaccines that people with autoimmune diseases can't take that are live vaccines, and again, these aren't in this category at all.
Okay, and a lot of people are also, of course, concerned about possible long-term side effects. So, a question from Michelle: How can we be sure that in, let's say, 5 years' time, we're not going to develop any long-term side effects from such a rushed vaccine? Anna, would you like to?
So, I mean, I think when people say rushed, they perhaps forget that some of these vaccines have been being developed for a long time before COVID happened. So, for example, the AstraZeneca vaccine, the technology was being used for MERS and for Ebola vaccines previously. So although it feels very new, it's actually a bit older than it feels. And we don't know a lot about this virus. We don't know how you're going to be in 5 years' time having had the virus. We presume that's a far, far higher risk than anything to do with the vaccine. The history of vaccine programs is that most of the side effects we see, just like in this, happen in the day or days after vaccination. And that's been the history of these programs. I think sometimes people think because long COVID can happen, perhaps long vaccination syndrome can happen or something. But there's no reason to think that, because long COVID seems to be a particular response to the virus. And as I've said, the vaccine doesn't contain the virus. It contains a little bit of the virus called the antigen, but there's no virus when you have your injection.
Yeah, and just to reiterate that, we're just discovering that people who've had the infection may have long-lasting problems in their body, in their brain, in their lungs, that may be there for years. So that's much, much worse than any theoretical problem with a vaccine. So yeah, another reason to not hesitate and get vaccinated.
Yeah. So it sounds like the message there is that people should be comparing the risks of not just getting the vaccination versus not, but rather getting the vaccination versus potentially the long-term side effects from developing COVID, right, 5 years down the line.
Yeah, and also just to say that part of the program we're doing here is to keep monitoring people long term. So the idea that we've now got nearly 300,000 people, we're going to be finding out what's happened to them long term. We're also working with the MHRA, and they have a yellow card system that anyone with anything serious is being reported. So everyone around the world is looking very carefully at this. So it's not like people are just being thrown in the dark. And at the moment, there are no, apart from those early allergic reactions, again, as Anna said, just in the first few hours or days, there haven't been any problems reported longer term. So I think so far it's all reassuring.
And just to bring it briefly back to kind of short-term side effects. So some of those systemic effects that we talked about, like headache, fatigue, there are also symptoms that are found commonly in COVID infection, right? So Tim, what should people do if they're experiencing systemic symptoms after their vaccine?
Well, as I said, if it's the common ones that you've seen here, generally it should fade away very quickly. And if that headache and fatigue, for example, carries on, and maybe you get sore throat and rash, or the fever persists and you start getting a cough, then definitely start thinking on day 3, I should get a test done, because we do know that people getting vaccinated, may have gone on public transport and on that particular day got infected whilst there's a lot of it around. So, if it lasts more than 48 hours, I would definitely say get a test, and stay isolating until you've had that test result. Hopefully, most of them will be false alarms, and increasing as the rate comes down in the country, there'll be less of these post-vaccination infections. But while rates are high, I think it could be either.
Okay, so we're running out of time, which is why we have to end the discussion for now. Thank you so much to Anna and Tim. Many of the insights that we've shared with you all today are taken from the vaccine information that lots of you have logged via the ZOE COVID Symptom Study app. Our team is obviously continuously working to improve the way we collect this data. So in the next 24 hours or so, there's going to be a new update to the vaccine questions in the app, so that you will be able to tell us the type of vaccine that you or someone that you're reporting for received, whether it was the Pfizer or AstraZeneca vaccine, or even the Moderna one if you're in the US. So if you've already added your vaccine previously, we do urge you to open up the app in the next few days and add this information soon, as it is really important for our scientists. And if you know anyone who's had or is about to have their COVID jab, please share the app with them too and encourage them to log their vaccine. And also remember that you'll need to update your app to receive this new release. Again, thank you to all the contributors to the ZOE COVID Symptom Study. I really hope that the vaccine data insights shared today make each and every one of you feel really proud of how you're helping to answer huge questions of public and scientific interest. And thanks to everyone for joining this webinar. I hope you found it interesting and thought-provoking.